Assalamu alaikum, dear colleagues. We are back on a weekly webinar. I'm really thankful to Farooq Khan for sparing his time. Just like others, previous colleagues, it is early morning for Farooq. And I'm really thankful to Farooq for sparing his Sunday to talk to us on a very important subject, and that's EOS guided sampling. I know it's a bread and butter for anybody who is doing endoscopic ultrasound, and as many as 70 to 80% patients who undergo EOS, uh, they undergo some kind of sampling, and this sampling indications and technique. Farooq is here. We can talk about it. We have other experts, Khalid Hassan and Nadeem Thiami, and unfortunately, Dr. Saad Niaz also had to join, but because of illness of his close relative, he could not. But otherwise, he would have been here as an expert. So, Farooq, all yours.
Okay, thank you very much. Hi, everyone. It's a pleasure to be here. I'm really grateful for everyone attending on a Sunday. And first of all, I'm grateful to Dr. Saad and Dr. Ghias, really, for giving me the opportunity to talk about this, which I think, as Dr. Ghias has said, is really, really the bread and butter of EUS. And I think if one thing which I would encourage from this talk, particularly for the trainees who are listening, is to encourage yourselves as well as your colleagues to learn this technique. And the benefits are immense, it's rapidly evolving, and workforce is really the key here. Okay, so what are we going to discuss? I want to get the basics right. So what does that mean? When we say FNA or FNB, which is fine needle aspiration or fine needle biopsy, I think what's very relevant to know is what's the paradigm of it. So what are the indications? And you would like to think, is it really required? What are the contraindications? We will also talk about consent. Is this safe procedure? If it's safe, are there any complications? If there are any complications, are there alternatives? I think what's also worth mentioning is the technique, and there will be a couple of slides that will cover the technique in detail, but largely what the technique comprises of is scope, the accessibility, what the lesion's looking like, and what needle am I going to use. But I left the teamwork in the last, and I think we must not forget that teamwork, by and large, in any skill that you're going to learn or you're going to perform, is going to play a major role. And a very essential part of teamwork is workforce development. Now, this isn't just about learning yourself, it's about preparing your nurses in the unit, preparing your technicians in the unit. And if you really want to develop service, then clearly you need to start thinking of a very strong team relationship. Now, that said, I like this program, which is now started by Dr. Ghias and Dr. Saad, and I have been asked to talk about on this. One of the things in a lot in this curriculum, which I think is very basic yet important. Okay, well, why do we bother, really? Why do you feel that there is a need for all this curriculum? Why there's a need for service development? Why do we want people to learn EUS? Okay, well, I'll just quickly take you on the review that was published a few years ago in Frontline Gastroenterology by Guy's and St. Thomas's group. There are 65 centres in UK which provide EUS service. And if you look at our population, you could clearly see that there are about 1 centre per million population. So there's one hospital that does provide EUS service for 1 million population. That's really not exciting, is it? And when you compare it to France, where there are 220 centres, and Germany, where there are 450 centres. And if you break it down, you will see that a lot of these centres, majority of EUS, what is happening is linear. And the major source or use of EUS around cancer management. So therefore, you and I, as a gastroenterologist who do EUSs, will be asked time and time again to assess the lesion and to take sample, by and large. UHL, where I work, in my center, University Hospital of Leicester, from last year data, we've done 76% of our EUSs were FNA and FNB. As Dr. Ghayas said, 70 to 80% EUSs that gets done are largely linear EUS. We also do a great number of radial staging, probably much more than center of our size. And we cover about 1.7 million population. And then there is therapeutics, which is about 10%. That involves cisgastrostomies, that involve celiac plexus blocks, judicial placements, all the other parts. This then take me to what we have discussed in the recent months and years in Pakistan, what the way, or in any developing country where EUS isn't really quite yet established, was the way forward. And you will see that this is where we need to focus in tier 2 teaching hospitals. And these are the hospitals either in Karachi and Lahore or around these bigger centers, but you will see that the 80% workforce development, that's where we need, and that's the population requirement as well. So yes, I think there's a greater need, and I will encourage trainees to get involved. What is EUS timeline? It's actually only 28 years. So it isn't really, you mustn't think that you've been left a long time. It isn't. I started doing EUS in 2013, so only 8 years, so not a lot. The first echo endoscope, if you like, were in flexible endoscope was in 1911, and the ultrasound was discovered in 1956. And if you like, the first radial echo endoscope by Olympus was 1982. That was only radial, it didn't really allow us to do much. And the first linear scope was formed in 1988, so 6 years down the line. First case of EUS FNA was from head of the pancreas and performed by Visema and Rob Hawes. That's from Dr. Khalid Hassan's unit. We knew it, they have been pretty much leading it from very long time. So when I looked at this since 1992, and I did my first EUS FNA in 2013, I felt rather reassured that I'm not really that behind the time. And therefore, I also encourage you to have a clear thing that this is where you need to take it forward. From 94 to 2003, once the first EUS FNA performed, there has been a huge growth on EUS FNA, of course, because now that you've got a scope, there's a needle, and that wherever the GI tract can take you, you could potentially reach and be able to do this. There comes a time in 2011 where you have chord biopsies. This is where FNA started to change its shape to FNB. So the first chord biopsy needles were these were by Cooks, they were reverse and bivalent of this. So therefore your needle goes in and you pick up more sample as you come back. So you pretty much scrape it as you come along. This carried on till about 2016 when your first core needles come along, Charcot and Acquire as they call them, and they've got fork shaped as well as Freenson, which is like a pencil tip. I'll talk about this in a bit more detail. So basically 1982, the first echo endoscope, 1988, the first linear, 1992, the first biopsy was performed, and now, as you've seen, so in my unit, we do about 1,000, just under 1,000 EUSs a year, and as you know, over 750 are biopsies. So the sky is the limit, really. So what are the indications? As I said, wherever the GI tract takes you and wherever the scope goes, you could. However, from the FNA point of view or FNB, we have largely restricted ourselves to upper GI as well as hepatobiliary system. So in the esophagus, you could use it for staging. You could, I get a lot of referrals for lymph node sampling. We also do what is called staging of upper GI cancer. And I just want to make a quick comment here. I know EUS, particularly the radial EUS, is not very effective for staging of esophageal cancer because it doesn't really add much to it. However, it's the late cancer where it doesn't. In my unit, we do a lot of radial EUSs for T1S, M1, M2 disease. Why? Because we want to know before we do EMR or ESDs that this patient has not got lymph nodes. And the lymph nodes sometimes are not readily picked up by CT scans unless it's a PET scan. And if your patient's got lymph nodes present with even M2 disease, then really we shouldn't go ahead and do EMR. So there are early stages. There's a lot of applicability of even radial EUSs. We also do fiducial placements. It's a technique that my radio oncologists want me to do. These are metal needles that get stuck at the top and the bottom, and they can provide brachytherapy. Whilst you're in the upper GI section, mediastinal lymph nodes gets referred many times, and people with chronic inflammatory disease, people with cancer staging, and you can access the mediastinal lymph nodes either on the right or the left side to try and take the samples. Stomach, again, staging, submucosal lesion, including GIST, quite commonly referred. I'm sure Linitis people have been doing. Our center have started doing stomach or Linitis biopsy since a couple of years ago, and I now get every 3 to 4 months, I get one referral from upper GI MDT. Again, lymph nodes. Pancreas is by and large the bread and butter, to be honest, and if you see a lot of FNA or FNB work is being done in the pancreas, either it's a solid, it's a cystic, or solid cystic lesion. Liver and bile duct, I've actually got a case to show you guys later on the liver. We do decent numbers of liver lesions rather than normal liver biopsies, although again, Dr. Khalid Hassan Units has presented a paper a couple of years ago that you can even do normal liver biopsies, FNB 22 gauge from liver. Cholangio or atypical HCC, where I get these referred. Biliary stricture, particularly distal, I think EUS has a role, and we still prefer to do FNB for those stricture or distal lesions rather than lymph nodes. Miscellaneous, I do often get referred retroperitoneal masses, and either it's inflammatory or it's malignant, lymphomas to access these masses. There's also some role in rectal lesion assessment, but there aren't many FNBs, if you like, or FNA has been performed on rectal lesions. So as I said, the sky is the limit. Wherever your scope can go, it is considered much, much safer than any other technique, i.e. CT guided. What are the contraindications then? And of course, if your patient is hemodynamically unstable, that is a problem. We wouldn't recommend you do that. GI obstruction, unless of course you're doing it for therapeutic reasons, i.e. where you want to drain an infected cyst in a very controlled environment. GI obstruction, where there's an excess issue, anticoagulation, I put there purposely really because I want to just, a lot of the data would suggest that the INR is over 1.5, and then you shouldn't really, and I tend to agree with that, although have I done FNBs in patients who INRs more than 1.5? The answer is yes, and if particularly they are cirrhotics, I have done on 1.7 as well. Platelets, if they are lower than 50, have a chat with your hematology colleague, and giving them bag of platelets really not going to do much harm. It's reasonable you do it. However, I wanted to stress upon this point really, particularly the beginners, particularly the new learners. Please make sure that you assess whether, if I'm going to do the biopsy, if I'm going to assess this pancreatic cyst, is it actually going to change the management? In a frail elderly patient, am I really going to achieve much by putting them under this procedure? So worth thinking about. How do I consent my patients? Is it safe? Well, let's have a quick look at the data. Bleeding is 0.13%. 10,000 patients on this meta-analysis, 14 had that problem, and so it's 0.13% is really, really low. Perforation, if you look at just upper GI endoscopy, the risk of perforation just by doing a gastroscopy is 0.03%. And we've seen now by research, by the evidence for EUS, and it's a linear, it's not the radial. So the linear EUS where you cannot really see, and most of the time the cervical intubation is largely blind, and the risk is not significantly raised, 0.06%. What about pancreatitis? Because I do biopsies, we do FNAs, we take pancreas lesions, and sometimes we actually do have to or end up going through a normal pancreatic tissue, then go to the lesion. If we have to, the risk is still not greater. And if you look at the data, it's about 0 to 2% at its worst. What about malignant seeding is quite rare. There's only 2 case reports, so it's not a major problem either. Biliary peritonitis, 1 case reports that required laparotomy, but patient had no complication. There were no death reported to it. So very safe. How do I consent? I generally ballpark figure, and I do tell my patients that if the risks in these complications are really, really low, it's around 1% as a ballpark figure. And they need to be aware of these really, but it's really, really safe procedure. I wouldn't, for the sake of the safety parameters, I think we mustn't decline this service to our patients. Okay, so what is a technique really? As I said to you before, there are 3 paradigms when we start talking about the technique. Very basic. One is a scope dynamics. What is a scope dynamic? And I have 2 things very important here. Either how can I access the lesion, right? Is it at the station 1? Is it easy for me to get there? Is it the D1 at the duodenal bulb, or is it actually gone past the ampulla in D2, D3, particularly the uncinate? So that's important. Short scope, long scope position, and access. Well, what about lesion itself? That's important. I think 2 things largely. One is the size of the lesion, and the other thing is what type of the lesion it is. Is it a cyst, or is it a solid, or is it a mixed? EUS needles, there are FNA, there are FNB, there are many, many needles, but we will talk about this in detail. When we start teaching EUS to our trainees or on the courses, we mentioned this 5-step technique to starting the procedure from node. So first thing we tell them is about the sheath and the needle, and the sheath, they're actually at 0. There's no needle sticking out. And I wanted to show you that image. If you see the sheath coming out of the scope, that's the safety of the scope. You should have at least 1 centimeter of the sheath out of the scope, and then you can manipulate. I've got a video to show you next. Stylet, yes, we do pull the stylet back to sharpen the needle, but once we're in the lesion, we push the stylet back in before we draw it, just to empty all the tissue or the mucosa for the stomach or the duodenum. Looking at the sample collection, I want to spend just a couple of seconds here. Yes, there are fanning techniques, there are different methods, but if this is the lesion that you want to go into, I would encourage you guys not to stop here. Why? Because my histopathologist tells me that as the tumor grows, the central area becomes rather necrotic, and you haven't really got much of the cancer cells. So really it's from starting point to the end of the lesion, starting point to the end of the lesion. So you can also use other modalities to enhance, and I'll just take you through a case in a minute and how we benefit from this. And the last thing is, how do you deal with your sample? You prepare slides, or you collect them in what we have, cytorage, and we send. This is our technique. We don't prepare slides. We don't have rows in our center. We collect the sample and they go to our histopathologist, where they spin them and they then put the wax on, and therefore then prepare the slides. Okay, so I hope this video gets to you. Really, this is I only prepared it day before yesterday. So starting the procedure, so this is a sheath that's going in. There's a luval lock at the end. This is very, very basic, but I wanted to just show you in real life why every single thing. The point number 1 is just the sheath should be at 0, and you should be able to see the numbers in front of you. That's how, and it's locked. Okay, so that's where you lock the sheath. That's the lesion that we saw in the contrast. We want to take a sample. We then, before we now go in, so I want to stop here. What do you think I did wrong there? Let me just reverse it back a bit. So I'll play it again. And there's something that I did that didn't really let me go. Right? Oh, sorry, I beg your pardon. Of course, I'm going to say this was all intentional. So you will see that as I tried to go back down, the needle won't go in, because what I haven't done, that I've just told you that you sharpen the needle by pulling the stylet back. I didn't pull it back. All right. So I had to stab once, it didn't go. I had to stab twice, it didn't go. You can see it on the screen, it didn't. And then I just pull it back, I sharpened the needle, and off it goes. All right. And as soon as it went in, you will see that the nurse will come there. She pushed it first, and then now she pulling it back. There is some evidence about slow pulling technique. I'll talk about that in a minute as well, but it's not that we quite do. What we do is we attach the needle and we open the suction 10 ml syringe, air filled. And when we go in, again, the sheath you can see bridge down, and you're in the lesion. You can see from starting point 1 to starting point end. Come back at the lesion, fanning technique, move your scope around. You can see the different part of the lesion. Now you go back in and you take samples. I think I've also got, yeah, so that's the course, beautiful one that we got, and that's how we collected it and sent it through. This was, by the way, an FNB needle. And I think, to be honest, since it's a solid lesion and since the advent of the FNB needles, I now rarely use FNA needle for the sample. So whatever FNB needle you guys have around, if it's a solid lesion, I would encourage you to use that. Okay, let's have a quick look at this case that I wanted to present to you guys. It's my patient. It was 78-year-old man, NASH cirrhosis. He was compensated, and his alpha fetoprotein was 4, and this was his CT scan. He was discussing MDT at least twice, and I will stop it in a minute as I come up. Oops, sorry. So he basically has got a large tumor in the left lobe, as you can see, which was, my oncologist wasn't very keen to give him chemotherapy, based just on the CT scan. His AFP was low, and they wanted to know whether it was just a cholangio or it is an atypical HCC. However, they've tried CT guided biopsy, they failed, and you can see clearly that it isn't quite obvious for them to take a biopsy. He was then referred, after he failed a biopsy, to myself, and as I've gone past the heart, normally when you push there, the first thing you get is the liver, but the mass was so large that I couldn't possibly get it. I really have to take the big wheel completely away from me to straighten it, and then I just saw the tip of the liver. So push the scope just a centimeter in, and you now have this fairly large lesion in front of you. And at this point, I wanted to put the Doppler flow on. So this is one of the other centers of ours where we do not have contrast and elastography in the machine. It's the old machine. So I'm using a SonoView now. And you can see that whilst there was absolutely this is very simple Doppler, come in a simple machine. There's nothing else I've done here. I went to my radiology department and asked for a SonoView, which is the sulfur hydroxide microbubbles, contrast, very safe, no allergies. It takes about 10 seconds to come into the lesion, and I now know that this is a bit that I need to go. To be honest, the largest the lesion, I don't like it, because I then rather get lost. Although people know that it's much easier to find, all I've done a very simple Doppler. This is a large liver lesion, and I wanted to see where the active and the live cells are. And all I'm doing, again, you will see the fanning technique. I've just gone to the knee. I've not come out at all. 3 samples there. Change the position again, and then take further more samples. This was the core we collected. Very rarely I had a call from my histopathologists to say that you've got a decent sample. They usually phone to tell us off that you haven't, in fact. But this time they didn't, because the sample was really good. And unfortunately, this guy had got HCC. He's now on chemo. Can I characterize these lesions better? Yes, there's elastography. Dr. Nadeem Tahami's center uses a lot of this, and he's presented a couple of weeks ago. That was a decent talk. And I think I would encourage also you guys to consider. Very simple. Green is good, blue is bad. It's pretty much the same technique that we have used so far in our liver assessment. Fibrosis is score. So basically it's the stiffness of the lesion, really. The softer the lesion is likely to be inflammatory, the stiffer it is going to be blue. This is the concept behind it. But if you haven't got it, that's fine. This was the lesion, if you look at it, that's a large lesion there. Again, just a sono view in the elastography image. There's a bit cyst there, so it's a solid cystic mass. And you see within 5 seconds that you start giving it, there's a lot of activity you've seen there. And this is where you need to target. So yes, contrast does help, particularly in places like where I work. We have a 28-bedded unit HPB ward, and at least 10 to 15 patients are chronic pancreatitic large masses. And we really, it helps us to focus or target our lesion better. Okay, moving on. Which needle really? So as I said, before 2010, we only had FNA lesion needles. We then have come along Procore, which was given the name of biopsy needle. So there were 13 randomized controlled trials in that era, really, of all the solid masses and lymph nodes. 8 RCTs, all looked at diagnostic accuracy. And if you see, they've not really suggested a significant difference. And that included the better accuracy, but lower with the lymph nodes in a solid mass. It was a better sample for rows, but again, it did not show much difference in the accuracy. They've added this up with the 2 larger meta-analyses. These were published early 2012. Again, there were no difference. So in that kind of time, there were no major changes to people practice. A lot of people have moved to Procore needles because visibly the sample was much better. But the studies haven't really shown one way or the other much different. We then have what we call F&B era. And as we know, the 2015 was the first needle came along. The Newcastle group here in UK, Manu Nair, presented this randomized controlled trial. Decent numbers, 100 to the opposing bivalve, like Charcot, and 100 to the Procore, just the reverse valve. I showed you the picture. The primary outcome was diagnostic performance, and they really found a very significant, almost about 20%, the sensitivity go from 71 to 90%, which was really good, and they've shown not much of the adverse side effects. A year later, Dr. Khalid Hassan's unit has presented this work. What they did, they've put Francine tip, like a pencil-shaped needle. Again, that's acquire type needles, and they combined this with rows. So what they did, that not only that they said, well, we're going to assess the needle, they said we're going to combine it with rows, and they did it on 30 patients, 6 with the failed FNA yield, and they've shown that diagnostic accuracy gone up to 96, 97%. I mean, to be honest, this is a really, really strong, significant data. And since then, 2017 ESGE guidelines came along, and they have changed their recommendation to F&B needle. As I said, for solid lesions, it's very rarely that I ask for FNA. We all now use F&B needles. Whichever you've got in your department, I'd encourage you to use that. Okay, but that will take us to the next point. What size really? Does the size matter? I don't think so. The concept of using a bigger needles to get a bigger tissue sample, to get a better accuracy, hasn't really been proven in the randomized control trial. So 19 gauge needle wasn't better than 22. And similarly, when you looked at the 22 gauge versus 25 gauge FNA needles, you have seen that doesn't much difference have been shown. If anything, what makes a difference really, I think, is where your lesion is. So what does that mean? So if you are assessing a lesion from the stomach, i.e. station 1, cardia, or even down the lesser curve, I think 22 gauge needle is fine and it will get you a significant yield. Even if you're in D1, you could still use 22. I wouldn't use more than 22 at that point, and it will get you the same yield. Now, if you've taken the scope down in the onset lesion for that matter, or retroperitoneal mass just around the mesenteric vessel, I still remember that case, you have to go really, really into D2, D3. I wouldn't even use 22, just use FNB 25 gauge needle, and it will, I've just shown you with the data that it will get you very decent sample. What about these adjuncts that we use? So slow pull techniques versus standard suction. And Pyle Saxena is an Australian gastroenterologist, was trained in Johns Hopkins, and she did that study while she was there. And she looked at 121 patients, 60 with a slow pull technique. So what a slow pull technique is that you puncture and then you don't attach a suction to it. All your nurse does is slowly pull the starlet out. And you compare it, she compared it with the suction, and she found absolutely no difference. None of us use it. It's not recommended either in the guidelines. Simple suction is fine. What about suction versus no suction? Multiple randomized control trials have really shown suction is relatively better, particularly if your needle gauge is 22 or over. Some people have said if your needle is 25, then there's not much suction in there really because the gauge is so small. What about fanning versus standard technique? A randomized control trial for the pancreatic masses compared head-to-head this technique, and they found a significant difference. We use fanning a lot, and to be honest, because I do not have rows, since we have moved to FNB as well as fanning technique, and our number of passes have gone significantly down. We usually now do not do more than 2 passes, and in each pass we try to limit a number to 5, at the max 6. Rows, there is no debate here really, and the evidence is all out. Is rows better? Should we carry on with? And I think the answer is yes. If you have got a pathologist present. However, if you closely look at the randomized control trials, you would see that the difference of reduced numbers due to pathologists being in the room and the passes being done less than more, it didn't actually quite translate it into the adverse effects. So if you can get a rose on site, it's ideal, it's perfect. But if you can't, it's not end of the world. We don't have it. I don't think we can. We are 3 hospital sites where we do EUSs, and it's very difficult. So we don't really have it. So yes, when you start developing service, have a think of it. If you can get it, fine. If not, it's not really end of the world. Last slide, you'll be pleased to know. FNA EUS guided is really rapidly evolving, and focus here should be workforce development, and the dedicated teaching is really the key here. For which you have seen that Dr. Saad and Dr. Ghyas has designed this curriculum. Every Sunday there's a teaching, and it's very, very useful, and I'd encourage trainees really to get involved. We in our center also have these short training benches. We also have 2 nursing courses, and we can online get people involved virtually if that's needed, but that's very doable. Encourage your teams around you to get involved in the training. EUS with FNA or FNB is actually quite safe. I've shown you decent evidence that there isn't, safety is not a concern. It's actually much better than any other techniques to obtain the sample. Please remember the 5 steps of tissue acquisition we've just talked about, and needle selection is multifactorial, but as I said, you stick to basics. I'll happily take questions now. I need to stop share, don't I?
Yes, please. Well, wonderful presentation, Farooq, as usual. You're a wonderful speaker. House is open for discussion. There have been quite a few questions which have been posted in the Q&A section. The first question is, should we be too afraid of bleeding, as now people can puncture through the vessel, including aorta, in the US for vascular intervention?
Sorry, I didn't hear that. Sorry.
Should we be too afraid of bleeding, as now people can puncture through the vessel in the US for vascular intervention?
No, not really. I mean, I am not, and there are reasons for it. Really, so if you puncture through D1, you are actually going through the needle, through the mucosa, out of the structure into a lesion, right? By definition, you have caused perforation. If you really want to look at it this way, but we do thousands. It never really happens with the vessels. Of course, we know that the intima is much smaller. But with 25 or 22 gauge needles, we don't see there's a much problem. Second thing, and you probably had seen in one of the cases where I just had a vessel right at the tip, particularly with the liver one. What I did, you can use your sheath to press the needle down, and then your needle to press this. You can use sheath to press the vessel down, and then your needle can come out. We don't seen that, and I've shown you the evidence. Even bleeding isn't really a major problem through these procedures.
But with the FNB needle, should we be going across the vessel wall?
With the
FNB needle, should we be going across the vessel wall? Like
no, please don't aim it.
Because I think that was a question by Dr. Gautam that with the
So please don't go for it. But if you have done it, it's not end the world.
Yeah.
One other thing is obviously avoid the vessels. But when you use, if it's a bigger vessel, when you use a FNB needle, that would bounce back from the vessel. Especially if you are going into the liver and you have a FNB needle and you touch the vessel, it would not like to go unless you are really persistent to go through that. And FNA needle usually goes through the vessel, and also depends on if it's an artery or a vein. So artery is very forgiving, veins are not. So because it says as soon as you touch that, go through that, it causes a spasm of the smooth muscles of the artery, and that really stops bleeding. But vein is kind of weaker as compared to artery. Bottom line is, if you go to, try to avoid. If, however, you go through it, don't try to keep going through back and forth. Okay, so if once you are in the vessel, try not to let the tip of the needle, bevel of the needle come out and then go through it again. So just stay there, relax, keep it through that vessel, and just do 2 or 3 back and forth without having to go through it again, and then just pull it out. Very, very low risk of bleeding. It can happen, obviously, and usually it happens with the people who are really persistent at puncturing the vessel.
Okay, there's another question. What circumstances do you prefer using FNA needle over FNB needle in solid lesions?
Right. There isn't really, to be honest. My practice have changed completely, and I really wanted to include a slide on if what kind of a lesion would be and what side would it be that would make what choice of the needles. Apologies, that slide has actually completely gone away from the presentation. I don't know how, but if it's a solid lesion, I do not use FNA needle anymore at all. It's the FNB needle by and large.
I think it also depends on resources as well. You can obviously FNB needle is expensive. In my experience, I really, whenever I give a talk, tell the fellows or whatever, I give a presentation, I always include this, almost always include this slide that every needle works really. You just have to figure out how it works, because all FNB needles itself, they don't work the same way. Boston needle is different, Charcot is different, Olympus needle is different, even though they all are FNB needles, but the technique varies, and you just have to learn that technique and how they are gonna work. So eventually, just once you get used to one needle, you figure it out how it works. It almost always works, but really you have to utilize your resources. Maybe you don't even have FNB needle because it's so expensive, and depends where you are working from. Are you If are you working from a rich unit like Farooq's unit or some poor country? And so really depends. So whatever is available to you, you gotta use it. For us, I have access to all the needles, and over a period of time, really, I have figured it out what works, what needle, how it works. So if it is a cystic lesion, you don't want to use FNB. That's my formula. And if it is a solid lesion and you have access, and especially if you don't have access to on-site cytology or rows, use FNB needle. If, however, you have access to a rose, then either is fine, FNB or FNA needle. It really all depends on your resources and your experience and what you are used to.
True, and don't forget that before the FNB needles came, even FNA people were doing good 77 to 78% sensitivity. So it's not that FNA needle is out of the question completely. And if you can get a rose, then I think FNA is reasonable as well.
Khalid, let's suppose that we have a rose and we have a choice between FNB needle and FNA needle. We have both the needles available. In a resource constrained place, is there any correlation with the size, that size bigger than 3 centimeter, FNAC needle and FNB needle, they're going to work the same, or there's not really much on that account that we can say?
Yes, it's a good question, actually. Not really. There's not, depending on the size, but especially if it's a lesion, which is 1 centimeter, or you're looking for metastasis. So for me, FNA needle with the presence of a rose might work better. And especially if it's a liver lesion, let's suppose. It's a metastatic lesion and it's 1 centimeter. They are very, very cell-rich lesions. So if you use FNB needle, you all have to go through the puncturing the liver capsule, then going through the parenchyma. You always put a little bit extra risk of bleeding in liver. In those cases, if you just use a FNA needle, 25 gauge, very rich cells in those metastatic lesions. So in that case, I might go with the FNA needle. So if the size is smaller, I prefer FNA needle. If the size is bigger of the lesion, and also Farooq has mentioned that before, that you want to go through the periphery of the lesion instead of in a bigger lesion, not in the center. And it's not like, one thing is the way Farooq explained that, like you go from one end and go all the way to the other end. Other option is you just stay at the edge of the lesion. Don't even target the center, just on the, just scraping off the edge. That's one I would do. So if the lesion is larger, I may just prefer FNB. If it's a smaller, I would go FNA. But really, it all depends what you are comfortable with and what you're used to.
And what is the disadvantage of having too many to and fro movements of the needle when you're using FNB? Is there an effect on the tissue crush, or it's just that we are good enough with 5 or 6 to and fro movements with 2 or 3 passes, as the tissue adequacy is good enough?
So for what I consider like FNB needle, once if it's when you go through the lesion, you kind of dug a hole in that area. Okay, so once the tissue comes in, now if you go into the same area, it's going to be all blood. So you have to change a little bit direction on that. And it again depends. If you are doing a liver biopsy for the parenchymal liver disease, then you don't want to go too many, like more than 2 or 3, because you're going to crush the tissue on top of each other. That's going to break the sample and fragmentation. So that's the problem with the liver biopsy, is that too many back and forth movements causes the crush effect on the more and more crush effect on the tissue and fragmentation of the tissue. So there you really want to do 3, maximum 4, or maybe even 2 back and forth movements. But as far as pancreas, or where you really need the tissue, where the crush artifact doesn't make a difference, it's okay to go more times. But with the core needle, again, depends on what core needle you are using. If you are using a Boston needle or a sharp core needle, you really need only 3-4 back and forth. If you are using an Olympus needle, maybe 2 extra back and forth on that, and use an intermittent suction on that. So it doesn't matter. You don't need a 16 for sure with FNB needle. You need to stay as less as possible. You can go up to 5, 6, 7 with the FNB needle, where the crush artifact doesn't matter. If, however, you are doing a liver biopsy, crush artifact does matter. Please don't do it more than 3, maximum 4 times, and do a longer specimen on that. So find a place from the capsule where there is not a big vessel, up to 4 or 5 centimeters down, and then just do one, and then change a direction, do a second one. I rarely do third one on that too, but not more than that, because more I do, more crush artifact, more I'm gonna fragment the tissue. So FNB needle, obviously less, depends on the location and what is the purpose of the tissue.
For the trainees in the audience, I just want to make a very quick point. It's not unreasonable to measure the lesion, because what you want to do, as you release the screw of the needle over the sheath, you actually then lock. So for example, if the depth at the farthest point is 4 centimeters, what you want to do is bring the screw down to the 4 and lock it. So this will prevent you from overshooting. That's just a safety tip, that if you're doing it right at the very beginning, that helps.
Farooq, do you keep the Doppler on when you're puncturing the tissue?
No, I purposely put, it's actually a very good question. I purposely put the Doppler off, because what you have to understand, these tips are really, really radiolucent. Even the sheath as well. So as soon as they come out, you've got Doppler on, it could actually spoil the image significantly. So I keep it till the point that the sheath comes out, if I really am worried about the vessels. And once I've seen this, when the sheath is out, I actually put the Doppler off before I go into the lesion. It's an important point, but I purposely put the Doppler off as I puncture the needle.
And also the Doppler, the way it picks up the signal is by the movement of the blood, really. Mm. So when you have a tip needle moving up and forth a little bit, that would pick up a Doppler on its own, even though there is no vessel there. It looks like a vessel, but there is not. So just, you can put the Doppler, and just to make sure there is no vessel, and underneath, and then just turn it off, go through it. And sometimes if it's just better not to turn on the Doppler, and you get scared, unnecessarily get afraid of the vessels.
But in Japanese communities, it's a routine to keep the Doppler on while doing the biopsy, while puncturing the sample, and throughout the procedure, they keep the Doppler on. I don't know what's the logic behind that.
I'm not aware.
That's fine. As long as you say that switch off the Doppler, we are perfectly happy with that. Another question about rows. Is it okay for the nurses to learn the rows and provide the service?
Okay, yes, honestly, after about a year's worth of war between histopathologists, so I'm going to expose a state secret now, but the histopathologists, we are really, really struggling in the UK. We really are, to the point that we're having to send images online across to other units to get the expertise. So we are now already started discussing that they will send a technician, a lab technician, to help us. It doesn't even have to be a trained nurse. So I don't see any problem why you can't train a nurse to look at the very initial slide under the microscope. To be honest, I did try to get my histopathologist to come and give us a talk 5-end at the end of this session, but she couldn't manage it around the time. And that would have been very helpful.
I can share our experience in Karachi, in Dr. Saad's unit and my unit. our nurses are very good in preparing the slide and having a look at that, and they take a picture with their cell phones as well through the eye of the microscope and let us know that look, these are the cells, and it's all positive. So we can share at least two centers who are doing this nurse mediated service, and we are pretty comfortable and happy with that.
Yeah.
Yeah, the main, I think anybody can learn it, honestly. And this is not a state secret in UK. Having access to cytopathologist or histopathologist anywhere is problematic. And there are going to be very, very few units, maybe even in the United States, where the cytopathologist can come to the room, really 10% or though, and give you a diagnosis. And all the time it's a cytotechnician, and that could be a nurse, that could be a trained cytotechnician, and their whole purpose is to make the slide and tell you, is there enough tissue there or not? And then you train yourself and how to take a look at the tissue as well. We had this study from our unit too. You can teach the fellows, you can train your trainees, and really that serves the purpose. So I think a nurse can learn that, fellow can learn that, we all can learn that. The whole purpose is you just got to make sure that your cytology or cytopathology department is okay making those slides, and they're not just going to tell you, oh, you guys made the slides, we can't read it, they're not made properly. You just have to communicate with them.
Well, there's lately been a very huge enthusiasm in doing liver biopsy through the US needle. Do you think that it's going to replace the percutaneous biopsy? Or is a special position or special situation where US guided biopsy has a definite edge?
So they're like percutaneous. I have not seen any single patient who did not have complaint of pain with the percutaneous biopsy. With the percutaneous biopsy, their needle is slightly bigger, no question about that. It's a 16 gauge needle they use. The biggest needle we got with our system is the 19 gauge needle, but we have a core needle. Main goal is to get uncrushed, unfragmented specimen which has at least 12 ported tracts and preserved parenchyma in that. And I think we can get that easily. I have proven that we can get that with a 22 gauge needle. And even though it's a kind of a squashed specimen a little bit, well, that's the best way to describe it. But 19 gauge needle, I think it gives a really, really good specimen with the proper technique. I think it would be best utilized in scenarios where because we get these EUSs a lot of time just for the diagnostic purpose, elevated LFTs, somewhat dilated bile duct, and cross-sectional imaging is negative. They end up getting an EUS, they end up getting referred for EUS, possible ERCP. And in those cases where you are already committed to doing a procedure anyway, and if you don't see any obstructive lesion and really don't see a reason to do ERCP, you just consent them for liver biopsy at the same time and do it in that scenario. That would, one thing is you're doing under already, they are sedated, and much less risk of pain, risk of bleeding is also less. So far what we have observed. And you are, if you are not going to do a liver biopsy at that time, you already did the procedure, you will have to send to IR or do to somebody else, do a percutaneous liver biopsy. So you prevent another procedure too. As far as head-to-head comparison between percutaneous and EUS guided, there is a study and from our unit as well, where kind of impression is percutaneous is better, but I have my reservations. I think we can
But the question,
we can
any
do the
particular
same.
situation where you think that biopsy is better?
What is it?
any particular situation where you may say that the US guided biopsy is better than a percutaneous biopsy? Other
Better
than
with regard to the specimen quality, or better with regard to the patient satisfaction?
In terms of indication.
Indication, I don't think there is a comparison. I don't know. Maybe it's like a cirrhotic patients. I don't know. Maybe it's better than percutaneous, and I really don't have evidence on that. It's better in particular situation.
Well, there's a question from Nadeem.
Never be in the situation
He
to
wants to know.
replace this, really.
Yes, Farooq, you want to say something?
No, certainly in UK, I don't think we will ever be able to replace the liver biopsy by EUS. Let's just face it. I mean, in my center, we do about 1,000 EUSs, the two of us. I mean, we can't even do cancer patients in time. That happens at times, really. It'd be very difficult to do just a simple biopsy. That's just a sheer number. There is no doubt that the liver biopsy is much better tolerated than a percutaneous liver biopsy, EUS guided. And to be honest, there are still centers who may keep patients overnight after doing liver biopsy percutaneously, and EUS takes that away. There's no doubt about it. So what do we do? Indications of liver biopsy, yes, if it's as I just shown you the case, whereby they have tried the other ways and means and they couldn't get the access, number one. If second, sometime if it's easy for me to access, to just get the diagnosis of CUP, which is cancer of unknown primary, and if it's a smaller lesion that other ways are not accessible easily, then again, if it's left lobe or even the caudate lobe, they usually ask me to go in and try it if they can. And to be honest, even if the MET is 1 centimeter over, you should be able to get a significant sample from the liver.
And in that scenario, where that's a totally different scenario with metastatic, I think there's no question that EUS guided works much better, even though we don't have a comparative studies, but no question in my mind that EUS is better if you have access to that. Because you can target it precisely with the EUS as compared to, otherwise they will have to do a CT guided, and that's more radiation exposure. So that one should be done with the EUS. We were on the topic of parenchymal liver disease, but for metastatic EUS access, you see it, no question in my mind, EUS.
There's a question from Dr. Nadeem Tehami about the role of elastography in contrast in US before going for US guided FNB. What do you think? Is there any particular role elastography? And
he's asked from you,
across the Atlantic, no role. On the other side of the Atlantic, a lot of roles. So I'll let Farooq answer that.
Okay, I completely agree. I think we had this debate, and I actually stand with Nadeem on this, to be honest. I think, and I've just shown you both of my EUSs, and the second one particularly, I didn't even have to use, because it's an old machine. In that unit, I don't have elastography. Simple contrast and a sono view had allowed me to that 6 centimeter HCC. It has just allowed me to target it really, really where I wanted it. And you've just seen it's very rarely the histopathologist will ring me to pat my back. They always ring us to tell us off that the sample was not enough. But you've just seen that it worked. So I do think, and the second reason, as I said, we have a 28 bedded HPB ward, and 15 of them are usually large, big inflammatory masses, or is it malignant? And I think for us, it works. So transatlantic, no. This side, I think we're going to carry on.
The kind of blue round nodule that you showed in your presentation, to be honest, I've not seen that in many occasions. Most of the time, it's a combination of blue and green, and it's always difficult to make out on elastography. Is it really that bad? But I agree. When it's classical blue, it's really bad.
Really
so I think I have said that before too. B for bad, green, G for good. So that's the easy way to remember.
That's true. We do that as well.
I agree.
I'm sure Nadeem does that as well.
7 in the evening.
So one other thing, a little bit, I don't know, maybe Farooq, you mentioned about the first FNA performed by EUS. Just want to clarify that that was Dr. Peter Willman from Copenhagen, Denmark. He's the one who did the first EUS FNA, and that was not of the pancreas. That was a mediastinal lymph node. Just FYI.
Oh, I see. Right.
And so he's the one who kind of helped make the first needle assembly for EUS.
No, I meant pancreatic.
Yeah.
Hence, I said head of pancreas. That was the Visemer and Rob Hawes who did the first pancreatic.
Yes,
wonderful. So excellent session. It's already 7. It remains for me to thank everybody. Thank you very much, Farooq Khan, for sparing your time. Thank you, Khalid. Thank you, everybody, for sparing your Sunday evening and Sunday morning for the people who are in UK or USA. It remains for me to thank the sponsors as well, and similarly, all the people who attended the session. I wish you all the best. Stay safe, stay happy, and stay healthy from COVID and all other diseases. Take care. Khuda Hafiz. Bye-bye. And next Sunday, there will not be a webinar. We are going to resume our webinar on 3rd of January.